Always, I want to start by acknowledging the traditional custodians of the lands that we're on. For me, that's the Wurundjeri people of the Kulin Nation, and to pay respects to elders past, present and emerging. And thanks everybody for making the time. Just to remind you again, as you've seen, we're going to record this and make it available on YouTube. We'll probably just put up the actual presentation and not the conversation afterwards, but just bear that in mind if you are making any comments, that if it's something you don't want to be in the public domain, perhaps leave it till after the presentation. So I'll not take time from Mark other than just to briefly introduce Mark. I've had the pleasure of knowing Mark for over a decade now. Professor Mark Stoove is Head of Public Health at the Burnet, not the Burnet Institute anymore, just the Burnet, Mark, I believe. Mark, the Burnet. Mark also leads the Justice Health and the HIV and STI prevention working groups. And Mark's undertaken research on the epidemiology and prevention of bloodborne viruses and sexually transmitted infections, and on the health and wellbeing of affected populations for over 20 years. Mark's research focuses on generating evidence for effective public health policy and practice. And today, Mark's going to take us through a presentation with the title Health Outcomes for Men with a History of Injecting Drug Use After Release from Incarceration, the Prison and Transition Health Study. So thanks again, Mark, for giving us your time. I'll hand over to you.
No worries. Thanks, Stuart, and thanks to you and Claire for inviting me to talk. I'll just share my screen initially, and can everyone see that? Beautiful Burnet new logo and design. We've gone orange, gone touchy-feely orange. Thanks all for joining us today. It was a bit of an ambitious project. This is a study that's been running for about 10 years now and has produced over 20 peer-reviewed papers, 3 PhDs and a whole bunch of really excellent work. And much of the work I'll be presenting today is from my PhD students. So I'd like to acknowledge them, but I'll acknowledge them as I go through. As typical, I've jammed quite a bit into the presentation, so I might just sort of move along relatively quickly. But I would, why is that not transitioning? That's interesting. Oh, there we go. I have to use the button down the bottom corner. My keyboard's not working. I would also like to acknowledge the Wurundjeri people of the Kulin Nation, the lands on which I'm sitting at the moment. I'd also like to acknowledge the artwork on the right-hand side. This was commissioned through our Reconciliation Action Plan and was commissioned through the Torch, which is a Victorian agency that supports Aboriginal and Torres Strait Islander people exiting prison with a pre to post-release transition program. And it fundamentally works around art and connecting Indigenous Australians back to their community through art and art training. So this piece of artwork was commissioned by the Burnet Institute and painted by a wonderful woman, Stacey, who was at Dame Phyllis Frost when she painted this work, and she's painted many other pieces of work. And I just found out recently that she was released from prison in the last few months. All of the proceeds of the artwork that's sold through the Torch 100% goes back to the artists. And she accumulated enough commissioned work in prison through the Torch that about a month ago she actually put a mortgage on a unit. So we all know how important stable accommodation is for people released from prison, and I'd just like to I'm so chuffed that Stacey's been able to, and the Torch has been able to support her to purchase her first accommodation. And it's the first time that the Torch has had a client that has come out of prison and actually been able to purchase their own, their own unit. And, it's just a wonderful, really wonderful program. And really stoked that Stacey's been able to do that and the Torch has been able to facilitate that. So that's Stacey's artwork. It's on our Zoom backgrounds and is displayed around the Institute as well on wallpaper and canvas. Quick overview of what I'll be talking about today. It's essentially, I'm going to give you an overview of the prison and transition cohort study that Stuart is also a chief investigator on. I'll go through the baseline characteristics of the cohort, briefly their post-release trajectories over time, I'll present a couple. What I'm describing is just some findings. So a few papers related to patterns of psychiatric wellbeing among people released from prison with histories of injecting drug use, and also the role of opioid agonist therapy in relation to preventing post-release injecting drug use, as well as and facilitating health service utilisation. And go into a little bit of current work as well that we're doing, and where we're heading with some of the data from this study. So why focus on people who inject drugs? Largely because they're incredibly overrepresented in the prison population because of the ongoing criminalisation of drug use. So we estimate that about half of people in prison have a lifetime history of injecting drug use, and about a quarter were injecting drugs in the month prior to incarceration. This is sort of historical data. These patterns may have changed over time, but traditionally, we know that this group is incredibly overrepresented amongst those entering prison, as well as those who are re-imprisoned. They return to prison at much higher rates than people without histories of injecting drug use. They also experience high rates of mortality, particularly in the post-release period, often due to overdose. And because of their churn through the prison system, they really, they're really core and a focus to the perpetuation of the individual social type of health and economic costs of incarceration. So they're a really important group to be working with and to understand, how to prevent health and social outcomes and reincarceration. So just briefly, a little bit about the cohort. It was funded through the National Health and Medical Research Council in 2011, commenced in 2012, although it actually commenced in 2013, thanks to some recalcitrance from the Victorian Department of Justice and Community Safety at the time, but we did get the study over the line, but that story's for another day, probably over a beer or two. For some people, it was a pretty harrowing experience. The chief investigators, myself, Stuart Kinner, Tony Butler, Campbell Aiken, Jim Ogloff, and Paul Dietz. And essentially the aims of the study is really it's a descriptive epidemiology study. We know very little about the trajectories and post-release trajectories of this community. So we're looking at the mapping the trajectories and timing of health service utilisation, drug use, physical and mental health, and criminal justice outcomes. We wanted to determine the health needs and examine factors, including those in aim 1 that were associated with meeting those needs. And really the most important part is to provide some evidence and data to identify crucial intervention opportunities to support the physical and mental health of this population and prevent their reincarceration. The design, it's effectively a prospective cohort study. So we recruited people in prison prior to their release, in the weeks leading up to their release, and face-to-face interviews at 3 months, 12 months and 24 months post-release. And accompanying that is extensive retrospective and prospective record linkage. Eligibility, unfortunately only males participated in the study. We had a female arm, but because of pressures at Dame Phyllis Frost at the time of program implementation, we were asked to restrict the study to male prisoners. They had to be sentenced, as well as one of the criteria was that they injected at least monthly in the 6 months prior to incarceration, and that was a self-reported determination. And health record linkage to health and law enforcement databases, and participants consented to record linkage at 2, 5 and 10 years post index recruitment release. Just want to go through some characteristics of the study. So we published this in the Journal of Urban Health. So this is essentially the protocol and baseline characteristics paper. We ended up recruiting exactly 400. By just complete coincidence. It makes it look nice that, it looks like we actually had a target of 400 and we hit it and then stopped, but it was actually coincidentally 400. We actually aimed for 500, but yeah, these are difficult studies to pull off, and we ended up at 400. Baseline interviews occurred a median of 33 days pre-release. Sometimes release dates were a little, unknown, and in some cases when release dates were extended out, we went back into prison and re-interviewed some participants to just update their time-varying baseline characteristics. So all data was the median time between data collection and release was 33 days. The average age was 36. We over-recruited Aboriginal and Torres Strait Islanders, not deliberately, but they are overrepresented among people with histories of injecting drug use and obviously overrepresented in incarceration statistics, but 17% is an overrepresentation relative to the Victorian Aboriginal and Torres Strait Islander prison population. I won't go into any of the details. We all know on this call that the levels of social and economic disadvantage in people experiencing incarceration is high, and it was particularly high amongst this group of people with histories of injecting drug use. And indicative of the ongoing criminalisation of drug use, the median prior adult incarcerations of our recruits was 5. And 45% of the cohort had reported juvenile justice incarceration as well. Just a few characteristics. This data really highlights some of the intergenerational disadvantage experienced. So a quarter of our cohort were removed from parents as a child, and nearly 2/3 of our cohort were also parents and caregivers. And looking at that intergenerational aspect, not surprisingly, for a cohort of males in prison with histories of injecting drug use, about half of the people who were parents or caregivers had child protection involvement, as well as 20% had a child ever removed from their care. There were a range of self-reported health morbidities reported by the cohort. Not surprisingly, very high exposure to hepatitis C. Dental problems were highly prevalent, followed by musculoskeletal and respiratory illness was also highly reported. The issues of comorbidities, mental health morbidities was huge in this cohort. So 83% had ever been diagnosed with a mental health condition, and 43% self-reported a history of diagnosis of 3 or more conditions, and really high prevalence relative to the general population of significant mental health problems. 17% bipolar disorder, 16% personality disorder, and 14% had a history of diagnosis of schizophrenia. In terms of in-prison drug use, so 65% reported ever injecting drugs in prison, 25% in a past incarceration, and during the index incarceration that we recruited from, 40% had injected during that incarceration event. I'd just like to sort of pause a little bit on that in-prison injecting. It's often swept under the carpet, and there are attempts to deny the existence of large amounts of drugs in prison systems, but we know, everyone on this call knows that that's not the case. Just a few things that we know to be true that sort of underpin, the human rights violations that sit around this is that, the governments know that, many people, and we know that many people enter prison dependent on injectable drugs because of the ongoing criminalisation of drug use. We know that a substantial proportion, as demonstrated in this study, will continue to inject drugs in prison because of that dependency and the fact that drugs are available. There's no access to clean needles and syringes, and most will reuse needles and syringes after someone else. And this is in an environment that government knows is the highest clustered prevalence of hepatitis C in Australia. And I'd just sort of like to get people to reflect on the fact that, I can't think of another area where government deliberately, through policies and practices, puts individuals at such significant risk of health harm. I just think it's absolute disgrace that governments in Australia and many parts of the world actually, through their policies and practices, deliberately put people at such significant risk of a health harm. I just sort of wanted to sort of have a pause around that, numbers of people who inject in prison and the type of environment in which they have to inject, and the lack of harm reduction in this country in prison. So their post-release experiences, I'll work through this relatively quickly. The purpose of the post-release experiences, which we published in Drug and Alcohol Dependence, these are serial cross-sectional analyses of our 3-month, 6 months and 12 months data. And the real point I'd sort of like to make here is the lack of change of people over time, and the ongoing significant health and social disadvantage experienced by people over the 24 months of follow-up. So we achieved an 85% follow-up rate with at least one follow-up interview, and I'd just really like to congratulate our research team for what a great job they did at achieving such a high follow-up rate for a population like this. It's very difficult following people from pre-release into the community, and they don't know where they're going to live, and they often don't have a phone number to provide us at baseline. 42% completed all 3 follow-up interviews, and we know across that 24 months that at least 18 people had died across that period. And this is just a couple of papers that I'd like to point to that we really wanted to also publish on the methods and how we achieved strong rates of follow-up, which we reported in BMC medical research methodology, and also in the Journal of Criminology. We published more of a reflection piece on how to undertake this type of research in prison, and a lot of that, the Journal of Criminology paper, is really around that balance of getting institutional trust to sort of go into prisons and ask these, sorts of sensitive questions, but also engendering trust amongst, potential participants in prison who often have a distrust of authority and needing to find that balance between, trust from the system, but also from the potential clients. Across follow-up interviews, a significant proportion were conducted back in prison, so 16% at 3 months, 28% at 12 months, and 41% of 24-month interviews were conducted back in prison. When we couldn't find people in the community, we prepared a list that we provided to the Department of Justice here, and then they looked through their records to determine which participants had been reincarcerated and provided us with information about what prison they were currently residing in. So we were able to do those follow-up interviews back in prison. And that sort of rate of interviews back in prison is reflected in the proportion of people. So all of this data is from the last time we interviewed. So at 3 months, 40% had been arrested at that time. And between 3 months and 12 months, 37% and 22%. This is the 3 months data. So between baseline or baseline release and 3 months, 40% had been arrested, 37% had been charged, and 22% had been reincarcerated within only 3 months. Between 3 months and 12 months, 59% had been arrested, 58% had been charged, and another 40% had been reincarcerated at least once in that period. And between 12 and 24 months, 62% had been arrested, 61% had been charged, and about half between 12 and 24 months of follow-up had been reincarcerated. So these rates of reincarceration, as I said, before, are really do perpetuate the social, individual health and economic burden associated with incarceration. Not surprisingly, homelessness, this group is, homelessness was highly prevalent, and again, did not change over time. Consistently, about a quarter of the cohort were persistently homeless, across our period of follow-up. Unemployment was ubiquitous over time, and again, did not change. So I can see that, that longitudinal data, or it was serial cross-sectional data, but the patterns were consistent over time, and really showed that the period of incarceration did very little to change the social, health and economic conditions of this population that they experienced prior to prison was really perpetuated post-release as well. I just wanted to go through a paper that Ashley Stuart prepared as part of her PhD. So we wanted to just look at psychiatric wellbeing in this cohort, but particularly changes in psychiatric wellbeing over time, over the follow-up period. Not just the prevalence of psychiatric wellbeing, but what were the things that were associated with changes in wellbeing. So we looked at changes in scores for the GHQ-12 over time, which is a screening tool for current psychiatric wellbeing. There are 12 questions across a 4-point Likert scale. So the scores range between 0 and 36, and that range becomes relevant to some data I'll be presenting shortly. A score of 12 or greater is classified as having poor psychiatric wellbeing, and the analysis outcome here again was change over time, not just the actual level of psychiatric wellbeing. We had a range of time-varying covariates and fixed variables that we wanted to look at in terms of, were these things associated with changes in psychiatric wellbeing, and these were determined through literature review. We used a linear mixed effects regression. I won't go into any of the details, but this approach is very good for the type of data that we're dealing with time-varying and non-time-varying variables, and some of the missingness and unequal and time at follow-up that we experienced in a lot of cohort studies with this population. So this is just some of the findings. The first finding I'd like to indicate is that psychiatric wellbeing or the lowest prevalence of poor psychiatric wellbeing was actually in that pre-release period. So whether that's due to having a roof over your head, 3 meals a day, maybe the anticipation that they're coming to the end of their sentence, but their wellbeing was highest in that pre-release period. It wasn't significantly different, but it was consistently lower in the post-release period. But you'll see here that the prevalence of poor psychiatric wellbeing and the mean score really did not change over time. And I guess if we examine this data cross-sectionally like this, we would assume, well, people have relatively stable psychological wellbeing in the post-release period. But what that average data does is it really masks individual variability. So this was actually the distribution of individual scores over time. So in the middle of that chart, those small bars right down the middle, that's the proportion of clients who did not change their psychological wellbeing scores from one follow-up interview to the next. And you can see over time that there's significant variability in individual psychological wellbeing through periods of follow-up. So again, the GH score ranges between 0 and 36. And just to summarise that chart on the right, around a quarter of the sample had a GHQ change score of 10 or more from their previous interview. So, a significant proportion having large fluctuations in their wellbeing over time. So what were the things associated with that change in wellbeing? What's affecting changes in psychological wellbeing? What I found interesting was the whole range of things that weren't associated with changes in wellbeing, and I've highlighted a few of them there, whether interviews were done in the community or prison, employment didn't affect change, experience of overdose, whether they were accessing drug and alcohol treatment, whether they've been arrested, or even whether they were a victim of violent crime between interviews was not associated with changes in wellbeing. These were the factors that were their baseline, so their in-prison baseline wellbeing, poor wellbeing, then predicted changes to poor wellbeing post-release. The amount of times they changed accommodation, so unstable accommodation affected wellbeing, as we'd probably expect. Injecting at high frequencies affected wellbeing, and also self-reporting poor physical health interacted with their psychiatric wellbeing as well. Of the things that were protective, Of interest is that those with higher numbers of previous incarceration were less likely to have psychiatric wellbeing deteriorate between interviews. So people who were at their first release were particularly susceptible to fluctuations in psychiatric wellbeing. Social support was associated with, was protective of declines in psychiatric wellbeing, and also having access to primary care in that post-release period was protective of people having poor or changing to poor psychiatric wellbeing. So some of the implications, we know from the literature, but that poor psychiatric wellbeing is associated with poor health, social and offending outcomes. So it's really important, that we think about that as, people's wellbeing, mental health and psychiatric wellbeing as something we need to support to prevent deteriorations in health and social outcomes, as well as protecting against reoffending. Some of the findings would suggest that we might want to think about targeted programs, particularly those with poor wellbeing pre-release, and potentially people completing their first period of imprisonment. How can we intervene early in someone's imprisonment trajectory to prevent them being re-imprisoned, or some of the poor social and health outcomes associated with going back into the community after someone's first imprisonment, and the stresses associated with that relative to people who are more experienced in the transitional process. Programs that would facilitate being protective of psychiatric wellbeing, programs that really focus on social connectedness, and we all know that stable accommodation too is just really important for post-release trajectories. Anything that could avoid, not necessarily avoid any injecting, but avoiding high frequency injecting, and anything that could connect people to primary healthcare service to support their physical health. But I'd also just like to highlight that the high prevalence of poor psychiatric wellbeing was really across the board. So really we need to enhance access to these types of programs for all people being released from prison. Just wanted to now sort of turn my attention to some findings around opioid agonist therapy. So, the previous work was by Ashley Stuart, who completed her PhD using PATH data. The studies I'll present now are from Michael Curtis, whose PhD was focused on the role of opioid agonist therapy in supporting people from prison to post-release. So this was a study that was published in Addiction, where we looked at the resumption of injecting drug use following release from prison. Very high rates of resumption to injecting drug use. Because of that high rate of resumption to any injecting drug use, we changed our outcome to an ordinal outcome. So we wanted to look at the predictors of having, and this is in the first, this is up to first interview, so the first 3 months. So looking at predictors of being abstinent completely from injecting drug use versus regular injecting drug use, irregular injecting drug use, so 1 to 4 days per week, and regular injecting drug use, which is pretty well daily, or we classified as 5 or more days a week. Ordinal logistic regression. In terms of the results, you can see there the very high prevalence of returning to any injecting drug use. So only 29% did not return to injecting drug use in that 3 months amongst those eligible for inclusion in the analysis. 23% reporting irregular injecting drug use, and about half of the cohort across the 3-month period were injecting at least 5 days a week, again showing the lack of rehabilitation impact of incarceration on preventing ongoing drug use. In terms of what was associated with regular injecting, there's a range of predictors there in green, but I'd just like to highlight the role of opioid agonist therapy was really strongly predictive of returning to high frequency drug use. And even more, just any OAT was not necessarily protective. When opioid agonist therapy was interrupted or was only initiated post-release rather than through a transition program, it was less effective. But the one significant component there was being retained on OAT. So taking the opportunity to introduce someone to OAT in prison or to maintain their OAT as they go into prison, and retaining them on OAT post-release was highly protective against problematic patterns of injecting drug use. Surprisingly, there hasn't been a lot of evaluations of the effectiveness of OAT in this pre to post-release period. So this provided some really strong evidence that, really supporting what we all intuitively know, but it was really important for the evaluation and ongoing support for these OAT programs in prison and their transitional programs into the community. We also looked at health service utilisation across a couple of studies. Firstly, the role of opioid agonist treatment on primary care utilisation. So we looked at counts of MBS listed health services, and we did a binomial regression, sort of looking at the role of opioid agonist therapy in supporting access to primary care as listed through MBS service items. Again, we looked at the role of partial versus complete OAT exposure. So those people who had OAT during part of their follow-up period versus all the way through their follow-up period. Again, trying to focus on the retention in opioid agonist therapy as a really important outcome. And these were separate regression models. So we wanted to look at different types of primary care access through MBS items. So these are separate regression models controlling for all the variables that you can see at the bottom of that table. In every single one of them, OAT was facilitative of primary care access through standard consultations, extended consultations, mental health consultations, after hours consultations, and accessing pathology services as well. So you would sort of expect to some extent in those standard and extended consultations, because OAT is prescribed through general practitioners. So you sort of expect to see those relationships there because people are attending those services just to be prescribed OAT. But you can see with some of the other consultations that it does have an ancillary benefit too. Simply being in contact with a primary healthcare provider and being given OAT then has ancillary benefits on other aspects of primary healthcare provision as well. Check your time. Then we looked at emergency department utilisation. So the other, the other side of the coin, we've got one area of the health system that you would like people to access, and potentially another area of the health system that you don't really want people to, have to experience or be required to access. So we looked at the role of opioid agonist therapy, similarly none, partial and complete, on contacts with ambulance and emergency departments, again using the same analytical strategy. And what we found was that while partial opioid agonist therapy across follow-up was not significantly associated with reducing emergency department contact, having complete or being retained on OAT between follow-up periods was significantly associated with a reduction in presentation to emergency services, either through ambulance contacts or emergency department contacts. Well, sort of in summary, some of Michael's work showed that opioid agonist therapy reduces risk of problematic patterns of post-release drug use, something that's sort of a bit like DER, but the dearth of information there, that evidence there was quite stark. So we're glad to definitively indicate that through the PATH study. But also opioid agonist therapy facilitates access to a broad range of primary health care services and is protective against contact with emergency healthcare as well. So it has all of these ancillary benefits, beyond just, drug treatment benefits itself. But really coming strong through all of that data is that retention in opioid agonist therapy generally enhances impact. So really needing to invest in those supportive integrative programs of OAT from in prison into the post-release environment and sustaining people on OAT over time. A couple of things in the wings that I'd just like to talk about at the end is we're very interested in the role of prisons and in-prison injecting on injecting-related injuries and disease. And Sam College-Frisbee, who did her PhD at NDARC and is now at Injury, which is in Melbourne, or the Injury office from in Melbourne, which is co-located with the Burnet Institute, is doing some work on the PATH data, looking at IRIDs and occurrence, hospitalisation through IRIDs. We know that people in prison are at risk of IRIDs through the sharing of and reuse of needles, through the injection of insoluble solutions that they use to mix drugs in, and also obviously the unsterile injecting environment where there's no access to needle and syringes. So often prison NSP programs and advocacy focus on bloodborne virus prevention, but the prevention of particularly the invasive infections, some of which are listed down there, is crucially important. Some of these infections are life-threatening, and also can result in really extended stays in hospital, and are very costly to the system, let alone the individual who experiences them. So all of those aspects are facilitative of IRIDs, but we also know that people in prison are less likely to inject or inject less often because of their more limited access to drug supply. So this is some of the preliminary data, but it's very early stages at this point. But we can see, relatively, high incidence, crude incidence of injecting related injuries and disease and infection and invasive infections. And we see that they're elevated during the prison period. So, but we also believe that that prison period is probably underestimated, because these are hospitalisations due to these types of injuries and infections. And we know that sometimes it can be difficult for people in prison to access healthcare to an extent where they may be transported to hospital from a prison setting. We're also doing some work around re-imprisonment, and this is some data that Ashley Stuart presented at the Lisbon Addictions Conference in Portugal last year. So we have the full history of incarceration for this cohort, not just from their index recruitment incarceration onwards, but we have all of their retrospective incarceration events as well. So we wanted to do some work looking at from their first incarceration episode, and looked at re-imprisonment across a lifespan, bearing in mind that this participant group were recruited in their mid-30s at their median of their 5th incarceration event. So this is a highly re-incarcerated population. And we wanted to look back at their trajectories in incarceration, so how significant this risk of re-imprisonment is. So we looked at all re-imprisonments from their first, from the date of their first release until right censorship at the 31st of December in 2021, or their latest prison entry date. Among the 348 of our sample where we had sufficient data, 90% had at least one re-imprisonment episode over time. And you look at this survival curve, that at 2.5 years, there was a 75% probability that this group were going to be re-imprisoned following their first incarceration episode. And this is the same data, Kaplan-Meier disaggregated by age. And you can see that when the people in this cohort were imprisoned at a young age, they were almost 100% likely to be re-imprisoned. So among men aged under 20 at their first imprisonment, by 2.5 years, almost all had been re-imprisoned. So as men age, in terms of when they were first incarcerated, their risk of re-imprisonment decreases. So that really accentuates that risk of re-imprisonment when people are incarcerated at a young age. And this data only landed in my lap late last night, and I'm still sort of dealing with it. Damien Perplesian is a very smart pure maths person that we've recruited from Stanford, who's doing some work, particularly around causal inference models with our cohorts. And he's looked at our data in relation to re-imprisonment over time, using that same concept of looking right back at people's first re-imprisonment. The figure on the right is re-imprisonment survival. So it's the probability an average cohort member will avoid prison over a particular period of time if they have a certain number of prior re-imprisonments. So you see the probability of, in those green and yellow lines, once people have had significant numbers of prior re-imprisonments, their probability of surviving, so to speak, in the community and not being re-imprisoned over time decreases substantially. So, as I said there, prisons are a beast that feeds upon itself. Really, re-imprisonment begets re-imprisonment over time, and you just get an ongoing cycle of re-imprisonment over time, and increasing probabilities the more people are re-imprisoned. On the right-hand side is the differences in survival relative to somebody who had no re-imprisonments at all. So the change in imprisonment risk for an average cohort member with a certain number of prior re-imprisonments relative to someone with none. And you can see, in those sort of blue to green lines that the relative risk of re-imprisonment is just substantial relative to those with no re-imprisonment. And also the confidence intervals around those, so the bands around those lines gets tighter with the more re-imprisonments. Our data is, you can see from our data that most people have been re-imprisoned multiple times. So our confidence intervals are actually lowest amongst those with few re-imprisonments, but we're really confident in our estimates amongst those people who've been re-imprisoned multiple times. So still trying to wrap my head around some of this data, but we'll be pushing on with some of this analysis around why we really need to break this cycle of incarceration and re-incarceration in this group. It's not serving the people who are re-imprisoned, it's not serving the community, it's not serving the taxpayer. This issue of re-imprisoning people for drug-related offences or for people who have histories of drug use, let alone all prisoners, people in prison, is just it's just got to stop. Here are I think all of the PATH papers and related papers. I can send these slides around to people who want them, but they're all available. Most of them are open access. I didn't have really time to just also acknowledge the work of Shelley Walker, who we had 35 PATH participants who were aged 24 years or younger, and she interviewed 28 of them in-depth interviews, sometimes multiple interviews that lasted 3 to 4 hours, just trying to understand the experiences of young people who have a history of injecting drug use, who are incarcerated. And some of this work is just and some of the narratives described by young people and their experiences, it's really traumatic to read. But she produced some wonderful qualitative work out of this study as well. I'd just like to acknowledge the PATH team of data collectors. Sorry, I forgot to put Kate Falconer's surname in there, and Emma Woods as well. the chief investigators who supported the application and continue to support the study. Others in our program, Rebecca Winter, Sam College-Frisbee, Damien Pecletion and Peter Higgs. And really like to thank the PATH participants who generously gave their time to the study and shared their stories and privileged insights. And there's my email address for anyone who would like any more information on the study. I might just stop there.
Thanks very much, Mark. That was a fantastic presentation, and you did a great job of covering a lot of ground in 45 minutes or so. So thanks very much for that. And look, for anyone who hasn't read those papers, Mark has led a terrific study, and there's lots of good stuff out there that's worth checking out if you get a chance. And Mark, if it's okay with you, we will find a way to make those slides available for people if they do want to have a look at them.
Absolutely.
Yeah.
Use and abuse.
Use and abuse. Okay, you heard it from the source. We have about 10 minutes for anyone who wants to ask any questions or make comments for Mark. So I'll turn it over to everyone else.
Mark, sorry, if you I had to tune out for a couple of minutes when I had an important email come through. So I'm paranoid I missed this part, but in New South Wales, it's like they've actually made it back in '89, I think it was made a criminal offence to bring a syringe into a prison. Do you know if does that exist anywhere else in Australia? Or
I'd say it. I'm not sure whether it's a criminal offence, but it's obviously contraband, and you'd be subject to a whole range, being banned from entries to prison. Lots of things. I'm not sure about the criminalisation of bringing a syringe in. Stuart, or anybody else on the call?
It's definitely the case in New South Wales, but I don't know about anywhere else. Yeah,
other jurisdictions.
I see Julie Tongs is on here. I don't know if Julie, whether you might know.
Hi, Mark and Stuart. I can reply to that question because I work in the prison. I'm very honored to have two of my supervisors in the same conversation. So hello, my name is Marwa. And in order to go to prison, there is a list of things that you cannot enter with. And if you break the confidence and they found something that you're concealing, it depends. So any sharps that goes in Victoria in and outside the prison, it has to be escorted with officers and counted, and there is a book of sharp that you have to sign in and out. So if it's going in legally and through a medical practice sheet that you're signing in and out, that's fine. If they found it out of that context, there is an investigation, a lockdown of the compound, and it depends after that, based on that investigation, if it's involved in a criminal situation or not.
And Julia, looks like you're unmuting yourself there too.
Yeah, I did. Yeah, I'm not sure. It's probably a breach in the AMC, but I do know that they do, they share needles and, they're injecting, and, it's really concerning. And even with the Hep C, people being reinfected with Hep C when they, return to prison. And here in the ACT, we've got the recidivism rates, I think 74%, and, can you send me the slides from today's meeting? This is the first one I've attended, but I found it very, very interesting and informing, because we do a lot of work in the prison and we run a full-time clinic out of the prison here. I know that it's one prison, but we have lots and lots of challenges, and and those challenges come from corrections and justice health. So, the pushback that we get, the lack of trust, when we went in there, we didn't go in there to be divisive. We went in there to provide proper health care. And in that process, we went in there as a standalone service because I wasn't prepared to share their risk. But we've had some really good outcomes around Buvidol. We do Buvidol in the prison. We chose not to do methadone because I think there's only one there should only be one methadone provider. And, you know, Woononga chose not to be that, because that's why we ended up in the prison full time in the first place, was because of a young man, Stephen Freeman, who died in custody back in 2016 from a methadone overdose. He was opiate naive and he had 2 doses and he died. So, but we've got a fella in there that's been on methadone, and because if you're on methadone in AMC, then you can't transfer to the Woononga clinic. So he's been on it for 18 years. He's got a very long sentence and he's come down off methadone so he can transfer to the Woononga clinic and go on Buvidol. So, you know, like we do other therapies and things like that, but like I said, you know, we don't do methadone in the jail, because it's and you know, the more people we get on Buvidol, the less risk there is of diversion and whatever. But the thing is that even it doesn't matter what you got in the prison, people are going to use, and there's no such thing as a drug-free, smoke-free or mobile-free prison anywhere in the country. If you got the money, you can get whatever you want. And
I'd say anywhere in the world.
yeah, right. So, but the thing is that it's concerning to me, because I'm already getting feedback about, you know, how they've stopped. Well, on Monday they stopped smoking in the AMC. And that's really, really concerning, because there's nothing for them men and women to do in there. They don't have any industry and they have very few programs. And now that they've stopped that, but they're already melting patches on jugs. They're melting the patches on the jugs, and they're paying $1 for a jail tea bag. And what they're doing is smoking, they're scraping the nicotine off the patch, rolling it with the tea leaves and smoking it.
Yeah. Oh, sorry, I was just going to add, when that happened in New South Wales, when I was in, the corrections came up with a fantastic solution to this problem. What they did was they banned tea, and this created a black market underground trade in tea bags. Yeah, just
nothing like proliferating contraband. It's unbelievable. But you've touched on a range of really important issues there, Julie. I think, you know, I presented at the Queensland Corrections and Health Wellbeing Forum a couple of weeks ago around prison NSPs, and presented some work from Tom Wright in New South Wales around the reinfection rate in New South Wales. And you know, about 40% of all hepatitis C treatments in Australia are now done in prison. So you've got a whole bunch of people who are now susceptible to reinfection, and you can see over time in New South Wales that about 30% of all hepatitis C treatments being provided in New South Wales now are retreatments. So it is just such an enormous waste of money to, you know, harm reduction, or, you know, from a bloodborne virus prevention perspective, it's a combination approach that works. You really don't want to cherry pick interventions, and that's the perfect example of, you know, expanded access to direct-acting antiretrovirals for hepatitis C, curing enormous numbers of people in prison, and then having them in an environment where they just get, you know, reinfected because they can't, you know, they can't prevent their infections reoccurring. It's just, it really is a disgrace.
And the other thing is that they're melting the lozenges down and shooting them up. So, you know, what's worse, you know, having a smoke or all of these other, now what's happening, you know, and what sort of issues is this going to create, you know, like health issues? I've seen where fellas have actually melted the patches down and they've been shooting them up, and they've got big blue balls on their veins like golf balls, you know, like, I don't know. I just think that, you know, smoking's the lesser of all the evils. Because have you seen what they smoke? They're like a bloody matchstick. There's no tobacco in them. I've tried, I can't even puff them.
That's not
I
ideal.
can't even get it out.
Mark, I'm aware that we're almost at time, but Monica Cass has got her hand up there for a quick question.
Look, I'm not sure. There was a time when I was pretty statistically literate, but a couple of years ago, I've kind of fallen off the perch, and I just saw that amazing graph that Mark was showing around the prisons feeding on themselves, and I have to admit I couldn't quite understand it, and I was wondering if you wouldn't mind just giving a quick explanation again of how to interpret the graph, because it looked amazing, and I bet it was really, really informative.
Yeah,
but I didn't understand it.
I'm still, like I said, it landed late last night from Damien, and to be honest, I'm still trying to wrap my head around it.
Okay, so it's not just me, because I was thinking, I can't understand.
Yeah, one was, sorry, I'm just trying, I think I've closed, oh no, I've got it here. I'll just see if I can share it really quickly, sorry.
It seemed to me, Mark, that it was basically saying the more prior incarcerations you had, the greater your risk of reincarceration soon after release. Is that?
Yeah, so you can see on the right, so those yellow and green bars are associated with numbers of prior incarcerations, and on the y-axis is your average survival sort of probability. So you can, and survival being, not being re-imprisoned. So you can see that, very soon after anybody who's had 15 prior imprisonments, you don't have to move very far along the x-axis before you're getting very few people who are not getting re-imprisoned, compared to those in the purple who are, there's that extended line where they're, if you look, for example, that intersects, 75% of people are, 25% of people are being or are not being re-imprisoned after 2.5 years. So, and on the right-hand side, it's the difference in probabilities of re-imprisonment relative to that purple bar on the left. So it's relative to those with no re-imprisonments, what the difference in survival is. And again, it's just that very rapid and cumulative return to imprisonment for those with re-imprisonment histories. So yeah, Damien's doing a whole bunch of work around this, and we do need to drill down to some figures and graphs and analytics that are most interpretive of the problem that we're dealing with. But in the end, being imprisoned begets being imprisoned. And like I said, we just have to stop it. No one, I'd prefer the decriminalisation of drugs, but at best, nobody should be incarcerated for a non-violent drug-related offence. Should be mandated community sentences for anybody. If we're not going to decriminalise, just don't lock people up for drug-related offences. Drug use is a health issue. It's not a criminal justice issue.
Thank you.
I'm aware there's a couple of people on this call who are at the BOXO conference in Sydney at the moment. So maybe you could go on and have a chat to New South Wales Corrections and see if we can get some reform happening. Look, I'm aware that we're over time, and I just wanted to thank Mark again very much for taking the time. I know you're in the middle of another meeting, Mark, so thanks particularly for taking the time out to share that with us. And thanks everyone else for coming along from all over the place as far as Canada. Lindsay, thank you for joining us from there. And just before we go, though, I just want to remind you our next presentation 5 weeks from now on the 15th of September is Dr. Megan Bell from UWA, and she's going to be talking about a remarkable study looking at a raft of health and welfare outcomes for the children of incarcerated mothers based on a big intergenerational data linkage study. So please come along. Mark, if it's okay with you, we'll share your slides as a PDF or something for people who may be interested. But just before we wrap up, everyone, please just join me in thanking Mark again. We'll do the awkward Zoom clap.
Thanks, everyone.
All right, take care.
Bye.
See you next time.